Today I'm going to talk about aspects of immunotherapy and then move into thinking about vaccines. And in my mind, everything that I'm going to tell you about today can be united under the general heading of ways we use our knowledge of the immune system to help people or to deal with different disease states. We have been talking about hypersensitivity reactions, autoimmune diseases, and we left off on Friday talking about transplantation. And we have seen some general similarities between some of these different types of responses. We looked at first solid organ transplantation, and we talked about the importance of MHC matching in solid organ transplantation. We then talked about bone marrow transplantation. And if you recall, we saw a unique challenge with bone marrow transplantation that we didn't have in solid organ transplantation. And so in bone marrow transplantation, if you remember, we have this additional complication called graft versus host disease, GVHD. In graft versus host disease, immune cells in the transplanted bone marrow can attack the host who has received the transplant and lead to damage of that host. And so here you can see our host getting a bone marrow transplant. That bone marrow involved a mixed population of cells, including some mature memory T cells, which are able to go to the lymph node in the patient and get activated because there are so many foreign antigens. This can be either direct or indirect recognition of MHC. And those T cells can then go to other tissues throughout the body and cause damage. And graft versus host disease can have different levels of severity, which are shown here. We left off last time with the idea that fortunately now we have a way to get around graft versus host disease, which is that we now don't do full bone marrow transplantation. Instead, we purify the hematopoietic stem cell, or the HSC, out of the bone marrow and transfer just purified hematopoietic stem cells instead of that full bone marrow. So here you can see taking some bone marrow, we've got this mixture of cells, and we can get rid of the other cells to just end up with hematopoietic stem cells. And then we can just transfer those stem cells, which removes this risk of graft versus host disease. We have, since this whole thing started, we've also found that hematopoietic stem cells do circulate in the blood, also making it easier for donors to donate in these situations. In addition, we can also say a little bit about the importance of matching our MHCs with our patient. And so here, what you can see is that is at the top, we see a situation where the transplant recipient is getting hematopoietic stem cells that are not matched. When that happens, all of those T cells are going to develop in the recipient thymus. So it's going to be donor bone marrow, but that donor bone marrow is going to develop in the recipient thymus. What MHC will be the restriction of that, of all of those T cells when they leave the thymus? Yeah, Sydney? Right, so the host, the recipient, right? So the person who got the transplant, which remember we're saying in this case is not matched. So now we're going to have a whole bunch of T cells that recognize blue as self, right? In theory, we want to activate T cells using dendritic cells, macrophages, all of those things. Where do the dendritic cells and macrophages come from? Yeah, the bone marrow. And so what MHC type are they going to be presenting on? Yeah. Not blue. The donor, yellow. So our antigen presenting cells are going to be presenting on donor MHC. The T cells are going to be looking for recipient MHC, which is going to be a mismatch. Those T cells are not going to be able to recognize the antigen that's being presented well. The patient is not going to be able to make a good adaptive immune response, and they're going to be sick. See, they're sick in bed. Look how sad. If, however, there is at least some match, then the T cells and the antigen presenting cells will be able to interact correctly, and our patient will be okay. And what you can see is this is really only requiring some amount of match. Oops. And so what you can see is that this is showing you the survival of the graft on the left-hand side. The red, this color blue, and the green are either a perfect match, a single class 1, or a single class 2 mismatch. And you can see they're all pretty much identical. So as long as you kind of have some matching, it's okay. It's only when you have multiple mismatches that you start to really have problems here. So there is a little bit more tolerance to mismatches here. And you can also look at the probability of graft versus host disease, which is highest when you have mismatches. For the next kind of piece of this that we need to talk about has to do with treatments. And we're going to first talk about some treatments that are related to transplantation. But some of the treatments that we're going to see overlap between these three situations because they are coming from the same kind of mechanisms in terms of the immune response. They're all sort of too much immune response if we think about Goldilocks. And as a result, they all could be treated in the same way by turning stuff down. This is particularly important for transplantation. We're going to talk about the transplantation therapies first. Because if you look, even when we have 0 MHC mismatches with a solid organ transplant, our organ only has a 33% chance of surviving in our patient for 10 years. And that organ is usually going to be rejected still within about 13 years. This is most likely due to minor histocompatibility mismatches because you're not going to have a donor and a recipient who are 100% genetically identical. There are going to be some antigens that are going to differ between them. And as a result, dealing with this and trying to give some treatment to our patients is really important, even with perfect matching. The main drug that is used in treating transplant recipients is cyclosporin A. So cyclosporin A is shown at the bottom of this slide. At the bottom, you can see the calcium, calmodulin, calcineurin pathway that leads to turning on NFAT. Cyclosporin A was which is this little orange oval, binds to calcineurin so that calcineurin and calmodulin cannot come together. And NFAT can never be activated. It just sits there in the cytoplasm, and we can never turn it on. So cyclosporin A, you can see here, is listed as the main target. There is another drug, tacrolimus, also known as FK506, that really does the same kind of thing here. But in both cases, these drugs are turning off T cell activation. The idea here is that the T cell may see antigen, but we will not be able to actually get signal 1 from that T cell. We will not be able to fully activate the T cell because we can't turn on one of our 3 transcription factors, NFAT. And so our T cell will not get turned on. So just to give you an idea of the success of cyclosporin, this gives you information on transplant survival at different times after transplantation. In the black is untreated, in the blue is treated with cyclosporin. And so you can see in the black we have this progressive loss of that graft. While when we treat our patient with cyclosporin, you can see that our graft is much more likely to survive. And so this should show you the dramatic success of cyclosporin. Transplantation really kind of did not take off, was rarely workable, wasn't something that was done very often until cyclosporin was invented. Cyclosporin has really allowed transplantation to happen. And you can see this here. So this is just the general 5-year survival of transplant patients, both before and after cyclosporin. And so you can see that transplantation went from this thing where there was a 40% survival rate to something where there's like an 80% survival rate with the advent of this drug. And so what I hope you get from this slide and from the previous slide is that cyclosporin was sort of revolutionary in making sure that transplantation was a thing and was an option for many of our sickest patients. And so I hope that you can see the big positives of cyclosporin here. You can also see, of course, that the way that cyclosporin directly uses information that we have previously learned this semester in order to make this drug work. However, I also want to highlight a couple places where cyclosporin is not awesome. And some of this is going to get into a theme that we're going to see a fair amount this week. So this part's not quite on the theme. The other point is, let's imagine that you had a patient who was suffering from hyperacute rejection. So remember, we had 3 different types of transplant rejection: hyperacute, acute, and chronic. So now let's imagine you have a patient who is suffering from hyperacute rejection. Would cyclosporin work for them? So Jamie, I see your head shaking. What are you saying with your head shake?
The problem with hyperacute is antibodies.
Okay.
They're pre-existing.
Right. So the problem with hyperacute rejection is antibodies. Cyclosporin is going to block T cell activation. And so cyclosporin is only going to work in situations where T cells are the problem. And you can see, in fact, it being listed as a target for some autoimmune diseases as well. It can be a good target if you are looking at a situation where T cells are causing the problem. If T cells are not causing the problem, cyclosporin is not helpful. And so this is why knowing the mechanism of what's going on with your patient can be important here. There's one other big issue potentially with cyclosporin. And again, this is a theme that's going to come up a few different ways today and also some later this week. Based on what I'm showing you here, can you envision any potential problems with cyclosporin? Yeah, Jamie.
Because you're basically not getting the T cell signal one, it's going to lead to some sort of immunocompromisation of the patient.
Okay, yes, that's exactly right. That's exactly what I'm getting at, but we need to think about why that is exactly. So Jamie says the patient's going to be immunocompromised with this. Why is the patient going to be immunocompromised with this? Yeah, Sydney.
It's turning off T cells indiscriminately because the cytoplasm doesn't target just the problem T cells, it turns off the anti-estrogen.
Exactly. This drug hits all T cells. This drug doesn't just hit the T cells that are attacking the kidney. This drug turns off activation of all T cells. So the patient is going to be able to keep the kidney, but they are also going to be immunocompromised. And so it's sort of this risk-benefit thing. They're going to actually have a kidney to be able to do normal physiological function, but they're going to be more susceptible to SARS-CoV-2 or something like that. And so with many of the therapies that we're going to talk about, we have this sort of tension. And this is actually a general sort of biomedical thing. And again, we're going to see this over and over. In that we have got some ways, in some cases, to address certain diseases. But in a lot of cases, many of them are pretty broad. And the general theme that a lot of people in the field are doing is trying to take those things that are very broad and make them more and more specific. So instead of hitting all the T cells, can you find a way to just hit the bad T cells or something like that? So that's a sort of a theme that we're going to see with different therapies. So again, remember that I used the phrase, we're going from having a very broad type of treatment to wanting to have a specific treatment. If you were to think about different body systems, do any particular body systems have, I don't know, specific as part of their job? Or are there any particular things that we've learned about in biology, human biology, where the word specific comes up a lot? Have you ever heard any professor use phrases like specificity and exquisite specificity and specificity and specificity and specificity? Any class where that word specificity comes up a lot? Yeah. This one! The immune system is, in fact, particularly the adaptive immune response, is known for being very specific. It's known for its specificity. As a result, immunologists and our knowledge of immunology has actually been really useful throughout biomedical sciences because we have tools that are specific that some other fields do not have. And so specificity is the thing we're trying to get. And you'll see that with some of the things that I'm going to show you. So one of the things that we can do in addition to cyclosporin, to treat some patients, is that we can use monoclonal antibodies. Those monoclonal antibodies are pretty specific. And here, our monoclonal antibody actually has the CTLA-4 regions bound to immunoglobulin tails. So it's basically CTLA-4 made into an antibody, CTLA-4 Ig. Now, when T cells try to get activated, those T cells are not going to be able to get signal 2 because this CTLA4 molecule is going to bind up all the B7 on the antigen-presenting cells. And this is going to lead that T cell to anergy instead of activation. Now these T cells that are responding to the graft can become anergic. And they're not going to respond again. So the idea here is that you could treat the patient for a brief period of time, energize all of the T cells that are responding to the graft. So basically make sure any T cell that's going to respond to the graft gets some time to get energized, gets time to get turned off. And then you can stop treating the patient. And then the rest of the T cells are okay. So you're doing this for a short period of time instead of cyclosporin therapy, which basically has to happen for the rest of the patient's life. So here, you're doing this by thinking about timing and trying to be more specific in your timing to limit which cells are active. Molecules like CTLA4 Ig are only some of those used here. There are also molecules that can block CD40, molecules that can block CD3, molecules that can block CD25, which is the alpha chain of the IL-2 receptor, molecules that can block JAK3, molecules that can block cell cycle so that the rapidly dividing activated T cell is turned off. And so there are a lot of places where we can get to these sorts of blocks. We're going to get at some of this. Some of these are not super specific. We're going to get at specificity more with some stuff in slides when we move into autoimmune disease. Do you have a question?
I just want to clarify with the CTLA4. So it's not that it's like specifically targeting the T cells that are affecting the graft. It's that we're just treating for a short amount of time. So we're hopefully turning.
Yeah. So we're basically energizing them all the ones that would get activated during that time. We're energizing anybody who gets activated during that. I'm making up a time month. Okay. And then we're hoping that, okay, everybody now who would be a problem has been energized, and now we can take away the treatment, is the idea.
Yeah, thank you.
Yeah. And so you can see a lot of different ways where our knowledge of the signal transduction cascade in T cells can be used in order to help transplantation patients. Before I get into similar kinds of treatments for some other diseases, I do want to tell you about another specific issue that comes up with transplantation. And so this is another problem with transplants. These data are, as you look at the numbers, a bit out of date, but the problem has only gotten worse since this was made. So on the left, you can see a graph showing the number of transplants that are happening per year in orange, and the number of patients who are in need of an organ in blue. And what you can see is that there are far fewer transplants happening than the number of patients who need those organs. And on the right, you can see the number of patients on the waiting list for different organs. And you can see that number is increasing over time. Again, this has only gotten worse since the times shown here. So what you can see is that there is much greater demand for organs than we currently have, than we're currently doing transplants on. What's the limitation here? Why are we limited? Why can't we give all these patients on the waiting list the transplants they need? Yep, Abby. So some of it's a match problem, but not all of it. Yep.
For most organs,
Yeah, the problem here is supply. There are more people who need hearts than there are hearts available. There are more people who need livers than there are livers available, etc. And so we also have this general problem that there's this pretty big shortage of many of these organs. And so I want to show you two pieces of information or two thoughts about this issue. One of them is completely like a public policy thing, but at the same time, I think it's an interesting thing when we're talking about transplantation and this problem that I should at least bring up and put on your radar. And this has to do with organ donation. So this is the percent of people who consent to being organ donors in different countries. You can see that there's some countries are super high, some countries are super low. In the countries that are shown in blue, they have something called an opt-in system. That means that you have to say, I would like to be an organ donor, and your organs cannot be donated if you don't say that. In the countries shown in red, they have an opt-out system, where you have to say, I do not want my organs donated, and otherwise they assume your organs can be donated. And so what you can see is that in countries where there is an opt-out policy, there is a much higher percentage of people who are donors than in the opt-in countries. And in a lot of ways, you can kind of imagine this as having to think about the lazy people. In the opt-in scenario, the lazy people are not organ donors because they did not do the very hard extra work of checking a box. In the opt-out countries, the lazy people are organ donors because they didn't go through the work of opting out. This difference, you could imagine, is one way that the number of available hearts, etc., could change pretty dramatically. And so this is a public policy part of sort of getting at this issue with shortage of organs that I just thought you should be aware of. Immunologists have also tried to come up with other ways to deal with this organ shortage issue. And so one thing that people have looked into doing is looking at things like using stem cells to regenerate tissue that is being damaged. So can we sort of get new organs to grow from stem cells? Or can we make mechanical devices or other kind of machines that can do these functions, either as an actual mechanical device or a bioartificial? And so can we say, if a person needs a kidney, can we grow them a kidney? Can we have them make a machine kidney for them that we put in? Sort of pros and cons to some of these things. For example, let's imagine that we figured out a way to grow them a kidney. And the reason why they needed a kidney in the first place is because they had an autoimmune disease that killed their kidney. You grow them a new kidney, the autoimmune disease is going to kill the new one too. And you're eventually going to have to make them a new one again and again and again. So you haven't totally solved the problem, you've just given them a kidney. So, you're solving part of the problem, but maybe not all of it. Depends on what happened to them in the first place. And you can imagine some sort of the mechanical devices having issues of their own. There also has been this idea of doing xenografts or xenotransplantation, which is transplantation of organs from other species. When people think about xenotransplantation, the species that is most commonly talked about is pigs. Particularly, they're called miniature swine. They are in no way, shape, or form miniature when I have seen them. They're big old pigs. The reasons for using pigs here are twofold. One, they're not a species that we're particularly endangered in or we're lacking in. You could imagine, we're not going to be doing transplantation from chimpanzees, given how endangered they are. There's not enough of their organs either. We don't have this problem with pigs. And it turns out that volume-wise, pig organs are basically the same volume as our organs, at least from these miniature swine that are like hundreds of pounds, and in no way miniature. Their organs are the same volume as our organs. And so they actually work the best, or sort of have been hypothesized to work the best for a lot of reasons. And so one of the questions for a long time has been how to do this. You can see that this is from a review in 2002. The top is from a table in 2007. There have been a lot of ideas about how to do this, in particular to do some genetic modifications of the pigs and to make genetically modified pigs that grow, basically like have a farm of genetically modified pigs with organs to be used for transplant. In particular, there is a gene called alpha-gal SARE that is in all pigs that we don't have, that is a strong antigen, and so you have to make pigs that don't make alpha-gal SARE, among many other things. So this has been, this was discussed when I was in grad school. I went to the pig facility to see the pigs because one of my professors was working on this. It's been discussed forever, and it actually happened and worked for the first time this semester. So here you can see publication from October 2021 of genetically modified pig with all of the genetic modifications that we thought would work being made, and then that kidney being transplanted into a person and that kidney being fully functional. So one might imagine that in the future, one of the ways that some of these patients who were on the waiting list may be able to get organs and continue to live is through xenotransplantation, which people are still doing a lot of work on. All right, so all of that had to do with some treatments for transplant, but we can also work on thinking about treatments for some of the other disease states we've talked about. So this slide is talking about some treatments that can be used to treat hypersensitivity reactions, particularly type 1 hypersensitivity reactions, which, if you remember, are driven by mast cells and IgE. This is sort of your classic allergy response. And you can note that some of these are things that you might expect. One of them is an antihistamine. You've probably heard of antihistamines. Antihistamines block the histamine receptors. Shocking. Another one you've probably heard of is epinephrine, also known as an EpiPen. That is going to, as it says here, stimulate CAMP production by binding to the beta-adrenergic receptor on a mast cell. The idea is that the mast cells do not degranulate with high levels of this. So you're stopping mast cells from degranulating with that EpiPen. We can also use cortisone, which I'll also show you on the next slide, which reduces histamine levels and also influences mast cell signaling. You may have heard of cortisone elsewhere. So what kind of molecule is cortisone? Yeah. It's a stress hormone. And it's also a steroid hormone. So it's a steroid, but it's also a stress hormone. And so cortisone, as well as other steroids like prednisone, can act in a number of ways against activation of immune cells. So they're going to turn off inflammation, turn off prostaglandins and leukotrienes, turn off trafficking, potentially lead to some apoptosis. So we're going to get very broad-based effects to treat our patient. And these molecules are nice as steroid hormones because they actually can freely diffuse across the membrane and bind to a receptor in the cell and then act directly as transcription factors. And so you can see there's that binding. The receptor is a transcription factor. It's a real simple pathway. And these can have pretty broad effects, as you can see here, on immune cells. So we are basically suppressing the immune system very broadly here with this steroid. So note, with the comments I made before about being broad versus specific, this is real broad. Not just T cells, kind of all the types of cells. We're getting really general, turning down the immune system. At the same time, if you need a relatively quick response, or if you don't know what's really wrong with your patient, this can be really important to just turn everything down. And so this is a very broad, a very easy, a relatively cheap therapy, but it has the downside of being pretty broad. You're going to be immunosuppressing your patient pretty broadly, and not very specific. But I also want to go back to one other thing. So Justin had heard of cortisol, or cortisone. And what did you say it was, Justin? Stress hormone. It's also a hormone that you make when you're stressed. What does that tell you? What does all of this tell you about what happens to your immune system when you're stressed? Yeah, Krishna?
It's suppressed.
It's suppressed. And so it's the same exact phenomenon of when you are under a lot of stress. That same hormone, in the same way, is going to be generally suppressing your immune response in a very broad sense. This is exactly how it works. And so many different stressors give you this response. If we think about allergy, there is one other big treatment to mention. And the other big treatment to mention is known as desensitization therapy. With desensitization therapy, patients are actually sometimes exposed to the antigen in a way that can drive production of Tregs and production of other types of suppressive immune responses. One of the most famous is sometimes sublingual treatment, so putting some allergen under the tongue to help induce a tolerance treatment. And so the idea here is that we can take a patient who is extremely allergic, who has a very strong Th2 response, and start to decrease their response by sort of giving them this tolerance induction. A lot of it is dose related, and a lot of it is delivery related. In situations like this, the most promising in terms of some of the desensitizations are actually with peanut allergies, particularly for kids who would go into anaphylactic shock if someone in their classroom opened a bag of peanuts, like that severe kind of thing. They can get to the point where they can live a life around peanuts. They're not going to be eating peanut butter sandwiches, but they're not going to die if they happen to be in a room with someone who opens a bag of peanut M&Ms. And so desensitization therapy is very useful in those kind of situations. It has not sort of always been super useful more broadly. So that's the final type of treatment for allergies. We can then also think about ways that we treat autoimmunity. This table gives a whole lot of ways that we can treat autoimmunity. One of the first and most famous ways that we treat autoimmunity is with cyclosporin A. Same thing. Here we have T cells that are overactive, and we want to turn those T cells down. Good news, we're going to turn down the T cells and help our patient not have autoimmune symptoms. Bad news, we're going to generally immunosuppress that patient. And so this is exactly the same as what we saw with transplantation. But there has been a lot of additional work in coming up with some other therapies for autoimmune diseases. And you can see some of them in this table. What you can notice in this table is that if you look at many of the drugs, and we're going to go through some of these drugs specifically, but if you look, many of them have things like MAB at the end of their name. If something has MAB at the end of its name, it's a monoclonal antibody against something. If something has sept in its name, it's somehow blocking a receptor. And so you can see we have lots of receptors getting blocked. We have lots of antibodies against things, treating many of these autoimmune diseases. And these are generally thought of as sort of the biologics. So the next kind of big biologic set of biologics that was described are shown here. One of them is an antibody against CD4. The other one that is much more famous, rituximab, is an antibody against CD20. And in both cases, these are used to deplete the cells of interest. So the idea is we have rituximab. It's an antibody against CD20. That antibody will bind CD20 on the surface of a cell. And we'll have an effector cell, probably an NK cell, killing this cell that had CD20 on the surface. The reason why that's interesting and important is that CD20 is on activated B cells, pretty much all activated B cells. And so in this case with rituximab, we are going to kill the activated B cells. If we were looking at xenolinumab, we'd be killing CD4 cells. Killing B cells with rituximab is really great in that those B cells are no longer able to make antibodies that are going to cause the disease. So if we have an autoimmune disease that is the result of excess antibodies, some problem antibody, we're going to kill the B cells and make that antibody. Hooray! If T cells are the problem, we're killing the T cells. Hooray! However, we have a problem. What's our problem? Yeah, Jamie. You're killing all the activated B cells in the patient. So now you have to hope that the patient is not going to get sick. You are going to have, again, you're going to be immunocompromising your patient. You can sort of think about it that, well, B cells need T cell help. So if you leave the T cells alone, the T cells can still do stuff. You're just getting rid of the B cells. So maybe it's a little better. Maybe the patient's not quite as unprotected. They still got CD8 T cells and CD4 T cells. They just don't have B cells. You can imagine if you stop the T cells, like with cyclosporin, that's also going to impact B cells. But here you're like, well, maybe it's a little more specific. It still doesn't feel great. But if your patient is in dire need, this is what you do for them. And again, this is sort of, these drugs have been revolutionary. We can also see, oh my gosh, CTLA-4 Ig, the same molecule I showed you before, where we have the extracellular domain of CTLA-4 bound to an antibody IgG domain, which will block the CD28-B7 interaction. And you can see this here. So what should normally happen is that we should have a cell getting signal 1 and signal 2. If we have this drug binding B7, remember CTLA-4 has a much higher affinity for B7 than does CD28. So in this situation where CD28 and this drug are competing to bind B7, drug wins because the drug binds so much better. The drug is going to bind to B7. Our T cells are all going to get energized. In the case of autoimmunity, you can't really stop this one. You got to keep treating the patient because it's not like you're going to ever really have any issues with this antigen stopping. There's not a timing issue. So again, you're immunosuppressing your patient. But there are a bunch of co-stim molecules, so you're only hitting one. So you're not maybe disabling the immune response as broadly. And so you're getting a little bit better. And then the other really big type of therapies that we have are the cytokine-based therapies. This is a short list. This list gets longer and longer and longer and longer and longer all the time, of antibodies that act against cytokines, either against the cytokine receptor or against the cytokine itself. And you can see these here as well. So we have antibodies that can actually neutralize cytokines, which you can see at the top. We've got TNF in little blue shapes, and we've got antibodies neutralizing that TNF, so it can't bind to the TNF receptor. We can also see situations where we have antibodies to the receptor so that the cytokine is not able to bind. And all of these will inhibit that cytokine signaling to inhibit whatever type of immune response is associated with that cytokine. This shows a number of different drugs that impact TNF-alpha. TNF-alpha was the first target for most of these. If you have heard of Enbrel, if you have heard of Humira, those are both anti-TNF-alpha therapies. In addition, there are therapies that block IL-6, which is tocilizumab. There are therapies that block IL-1. There are therapies that block IL-22. There are therapies that block IL-17. There are therapies that block IL-23. This is a booming industry. And this has been, again, phenomenal for patients. These are data on an anti-TNF. This is Humira data, which was really, again, the first one, looking at patients with rheumatoid arthritis. And here they're showing C-reactive protein, which is a protein that's a problem in these patients. Swollen joints and pain, and you can see the placebo-treated patients have a lot of this protein that's bad. They have a lot of swollen joints. They have a lot of pain. And you can see that really within about almost a week of treatment with Humira, how much those patients are cured. I can tell you that I have family members who are on some of these medications, and it has been life-changing for them. I mean, completely and totally life-changing. And so these drugs have really revolutionized patients' lives. But we, of course, also have to think about one other piece to them.
Hi, I'm Phil Mickelson. I've been fortunate to win on golf's biggest stages. But when joint pain and stiffness from psoriatic arthritis hit, even the smallest things became difficult. I finally understood what serious joint pain is like. I talked to my rheumatologist, and he prescribed Enbrel.
Enbrel can help relieve pain, stiffness, and stop joint damage. Because Enbrel, etanercept, suppresses your immune system, it may lower your ability to fight infections. Serious, sometimes fatal events, including infections, tuberculosis, lymphoma, other cancers, and nervous system and blood disorders have occurred. Before starting Enbrel, your doctor should test you for tuberculosis and discuss whether you've been to a region where certain fungal infections are common. Don't start Enbrel if you have an infection like the flu. Tell your doctor if you're prone to infections, have cuts or sores, have had hepatitis B, have been treated for heart failure, or if while on Enbrel, you experience persistent fever, bruising, bleeding, or paleness.
Get back to the things that matter most. Ask your rheumatologist if Enbrel is right for you.
Enbrel, the #1 biologic medicine prescribed by rheumatologists.
So that gets at sort of the downside of this. Why did we have to have that voiceover telling us that long list? More like half the commercial was that voiceover. Why do we have to have that? Yeah, Rishi. Lawsuits, yes. But specifically realize this is all because these drugs, while great, are all very immunosuppressive and can potentially lead to a lot of issues for our patients. And so we're basically, as I'm showing you, revolutionizing our patients' lives in terms of their autoimmune disease, but there is this serious side to it too. And just as with any of the other things, we can look at multiple signal transduction events throughout T cell activation and see inhibitors that are in process or in the clinic to help inhibit. So this is great, and it's awesome to be able to see how the field is helping these patients. It also shows us some big places where we need to do better in terms of needing to take what we went from such broad treatment like steroids that take your entire immune system and turn it down to now turning down TNF, which is way better because then you still have IL-1 and IL-6 protecting you for inflammatory cytokines. But you still end up with a drug that has that many side effects and that much voiceover. And so everything we can do to keep narrowing that window of what our drugs are hitting are going to help our patients do better. And so what I hope that you kind of see, we've come a long way, but there's still a long way to go. There is one other thing that I need to point out here. Many of the drugs that are shown here are antibodies. In most cases, they are administered to the patient by injection. And in what I'm telling you about antibodies and everything I've told you thus far, you might have a little bit of a question or a problem. If you recall last week, I told you about something called a type 3 hypersensitivity reaction. What was a type 3 hypersensitivity reaction and why might it be important here? Yeah, Jamie.
It was the immune complexes.
So it was immune complex disease. How's it related to all this? Yeah, Sebastian. Okay, so you have an antibody to some foreign antigen. You're making some immune complexes that are getting stuck, and there's something about concentration of antibody and antigen. What was the example I gave? Yep, Jamie. Passive antibody therapy leading to serum sickness. So remember we had the black widow spider bite, and you were getting treated multiple times with black widow spider bite, and you were making antibodies against the antibodies. So I gave you antibodies from a horse, and you were making anti-horse antibodies, and that was causing you a problem. One thing we didn't actually mention was that you also would attack and degrade those horse antibodies, and they would not last as long in your body. And you would not be able, they wouldn't work as well in protecting you against black widow spider bites. And I still want to know about your life choices. And so we talked about this problem. Now I've just told you about all these drugs, this sort of hot, really like the hottest sector in pharma of drugs, are antibodies we injected to patients. And somebody doesn't get, my family member who has this has been on one of these antibody drugs and injecting themselves with antibodies since 2002, maybe 2003. So Why am I not, what's up with type 3 hypersensitivity? You could see there's a problem here. How is this person able to keep getting antibodies over and over and over again? How have they not made an immune response against those antibodies? To eventually, they inject themselves with anti-TNF or whatever, and their body just kills that foreign protein, and it doesn't work anymore. How does this work? And so one other piece that I want to make, or one other piece of this I want to point out, is that when we are using these antibodies, and when we use antibodies as therapies, we are actually using antibodies that have had a fair amount of work done to them, and are generally either humanized or fully human antibodies. And so what originally, people had done is they had found a mouse antibody that worked against our antigen of interest, and through biotechnology means, we're able to take the genes encoding the variable regions from the mouse antibody and put the rest of it onto a human, before a human antibody, constant region genes, so they could make what was basically just the heavy chain of, or just the variable region of mice for mouse antibodies, all the rest humans. So it was mostly self, but there was still part that wasn't self. They could then actually clone out the CDR1, 2, and 3 regions and just use those on the rest of a human antibody backbone. And now we also have ways to make fully human antibodies. There are mice that have the full gene knock-in of the entire human antibody combining region, so you can actually make human antibodies in a mouse. Or there are some cell lines. There's a cool mouse called the Velocimune mouse that is used for that. There are also some cell lines that let you do some of this, and so you can get fully human antibodies. And so that actually gets rid of that reactivity problem, and we don't really worry about this reactivity problem nearly as much. There is a very small amount of reactivity that happens where you actually get reactivity against the combining site, but that tends to not cause a problem with therapy, at least not for many years. If you look at any of those drugs that have MAB at the end, the letters before MAB tell you how the antibody was made. So if, for example, it's OMAB, that means it's a fully mouse antibody. If it's ZMAB, it's a mouse antibody with human variable regions. If it's ZUMAB, just human CDRs. If it's UMAB, it's a fully humanized antibody. And so there has been a lot of engineering on all of these antibodies in order to make antibodies that can be used in patients. I see people writing, so I'll let you finish writing before I move to the next slide. All right, so I'm going to switch gears a little bit here, though this gear is, again, broadly thought of as how we use immunology to make life better. And this has to do with smallpox. The story starts with smallpox. So smallpox is caused by a virus, variola virus. Variola kills about a third of those who are infected, and many of those who live are disfigured and will have scars for life. If you read old-timey literature and hear about somebody who's pockmarked, that means they're covered with smallpox scars. This was a very, 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 very common thing. It's estimated to have led to at least 300 million deaths in the 20th century. And infection with this virus causes high fever, usually greater than 101, head and body aches, vomiting, and then a rash that will lead to some raised bumps and pus-filled blisters that will crust fall off and will leave a pitted scar. You can see pictures of smallpox infections here. And if you would like to read all of the gory details about exactly how smallpox kills you, you can read the link at the top. But like I said, it's gory. So this was a terrifying disease for many people for many years. And now it's gone. Completely. This virus exists in 2 laboratories on Earth and has otherwise been fully eradicated from the planet. So there was some knowledge about how to deal with this or how to prevent this virus going way back. I showed you on the first day this quote from Thucydides from the Peloponnesian War, where there was this idea of having recovered makes you safe. And in many different areas of the world, some of the first citations are in Turkey, but in fact there are similar things in many areas of the world. We know that people were taking material from scars or from the pustules of infected individuals and injecting it into others or inhaling it. Particularly because it seemed like if you got it through breathing as opposed to getting it through the skin, maybe you got a different type of infection. And so, or if you got it off of someone else's skin in a controlled way, you had a much lower chance of death. You didn't have no chance of death, but you had a lower chance of death. And you might be protected. This is Lady Wortley Montagu, who was the wife of the British ambassador to Turkey in 1717, who wrote about this to one of her friends in England. Hey, and she's like, hey, in Turkey they're doing this thing where they engraft people with some material from a smallpox scar, and that protects you. And we did this to my son, and it's awesome. You should totally do it too. And so there was this idea coming from a number of places. If you actually also look at American history, you may have heard of Cotton Mather, who was sort of important in the New England area in the early 1900s. He had an enslaved person named Onesimus, and Onesimus actually taught Cotton Mather this process too, because it was generally practiced in Africa at that time as well. So there was this idea that somehow you get some of this virus and it makes you protected. In fact, there have been cases, so people used to actually mail smallpox scabs to each other, to inhale. There have been a bunch of cases where historical societies have old letters that they open and they're full of smallpox scabs. And because we've eradicated the virus, suddenly we're it becomes a biosafety national issue when some historical society opens some materials, which because they're totally up for biosafety at the historical society. And this led to the first immunological experiment where Edward Jenner took cowpox and said, hypothesized that it could protect against smallpox. He injected an 8-year-old boy, James Phipps, with cowpox and then actively gave him smallpox. And he lived, hooray, happily ever after. No ethical issues there at all. And this sort of was the first immunological experiment, like I said, done in 1796, published in 1798. The second person he did it on was his own son. This basically showed that you could use cowpox to protect against smallpox. This was done routinely. This is because of cross-reactivity. This was done routinely to the point where the World Health Organization was able to declare this virus eradicated from Earth on December 9th, 1979. The last natural case was in 1977. Vaccination was stopped in the 70s. So right now you only get vaccinated if you work with the virus. So I am certain that I am the only person in this room who has been vaccinated. And we will talk more about vaccines on Wednesday.